It was Dr. Ravi was online. He was waiting. Now he has to join because his next lecture is coming. So the pharmacology is related to, as per the CCLS protocols, we should remember the route, the dose, the dilution, the vehicle, method, infusion, bolus, all these things are very, very important. There's a very limited knowledge is necessary for these things rather than giving in the lot of details. So that much part you must learn, particularly when you are treating the emergency patients. And it was now, Vivek, are you there now?
Yes, sir. Yes, sir.
So
should I start?
Yeah, wait a minute, wait. Let me make few things clear. There are two lectures added after Dr. Vivek Gupta's lecture are stroke and acute coronary syndrome. Now, these two are being added in the course as just overview. You are not supposed to treat these conditions. You are not treating stroke. You are not treating acute coronary syndrome. But you need, as a CCLS provider, there is a role that you identify them and counsel the family members and put them to the right doctor. It could be a cardiologist or a neurologist or a neurosurgeon, and you should know which immediately investigations are necessary. Second point is, like in cardiac arrest, we were working in seconds. This is not even minutes sometimes. Like that, anything where there's a vascular emergency, and stroke and acute coronary syndrome are both vascular emergency, like an trauma having an arterial tear or ruptured vessels, or where you need to work in limited time frame of hours. So these two are also, we must understand that you have to work in a fixed time frame to get the best outcome. But before that, we'll have one of the most important lecture after the ECG, the interpretation of bradyarrhythmias and tachyarrhythmias and that management. So over to Vivek.
Thank you, sir. My screen is visible?
Yes.
So good evening, everybody. After a wonderful discussion about the pharmacology, we are going to discuss another important topic, tachyarrhythmia and bradyarrhythmia. So far, in last 2 days, we have talked that a patient we come across has a sudden collapse. When we check the pulse is not there, he is not breathing, and we start with the CPR, we give shock, and we manage this patient. But this is not the scenario all the time. As a CCLS provider, we come across more commonly with the tachyarrhythmia and bradyarrhythmia. These arrhythmias we can see at a different in different situations. If a patient has presented to the emergency department with these arrhythmias, or even immediately after the post-resuscitation, it is the tachyarrhythmias or bradyarrhythmia. If not treated aggressively, probably again the rhythm will generate to a cardiac arrest. Similarly, we can come across, as we were talking about the links of the during the CCLS, 4 links. So the first link was prevention of cardiac. So this another emphasis on in the ward area, in any ICU or in any hospital area, we are coming across with this kind of situation that patient is having tachy or bradyarrhythmia. So we treat it aggressively so that it does not degenerate to a cardiac arrest. So when we see the carotid pulse is present, it means, and patient is conscious, sitting and talking, it means we have a time, patient is not having cardiac arrest, and we have a time to analyze the rhythm. But if a patient, whatever arrhythmia he has, but if there is no carotid pulse, it means we have to follow the cardiac arrest protocol, which includes high performance CPR, starting with the chest compression, looking for the rhythm as soon as we get an opportunity. While continuing with the CPR, we analyze the rhythm after attaching the monitor, and we decide that the rhythm is shockable or non-shockable, and use defibrillator as soon as it's a shockable rhythm. And we start administering the drug, and the first drug and the most important drug is the adrenaline. This is what we do when we come across with a cardiac arrest. But when the carotid pulse is present, patient is conscious, talking to you, making some complaints uh, in the form of palpitations, misbeats, chest discomfort, breathlessness. So all these things, when they are present, you have a time to do a rhythm analysis. When we talk about the cardiac arrest protocol, it's the shockable rhythm. We have already discussed that if it is the ventricular fibrillation or pulseless ventricular tachycardia, we administer shock immediately as soon as we identify the rhythm. If it is a non-shockable rhythm, we continue with the CPR if it's the PEA or AC. So when we do the rhythm analysis, when a patient has presented with certain complaints or we have analyzed some changes in the rhythm on the monitor, this can be a tachyarrhythmia or this can be bradyarrhythmia. So by definition, we see any tachycardia is when the heart rate goes beyond 100. But usually a patient will not be symptomatic. Patient will not make any complaint. The patient complaints arises if the heart rate goes beyond 150, and the usual complaints are I have palpitation. I'm finding that my heart is beating at a very fast rate. Similarly, by definition, we say bradycardia when the heart rate is less than 60, but patient doesn't show any symptoms of bradyarrhythmia until the heart rate goes below 50. So, what brings a patient to you as a CCLS provider? Whatever the situation is, whether it's the emergency department or a ward area, you have been called as a part of early warning sign scoring is there, and you are a part of rapid response team to a ward area, or you are coming across any patient in the post resuscitation phase. The patient presenting symptoms can be a patient may complain a dizziness, lightheadedness, or may complain a syncopal attack. Our patient can complain that I have a very rapid heart rate, the palpitation, or if there is a bradyarrhythmia, patient may complain a misbeat, and definitely patient may have the chest discomfort as well. So these are the symptoms which brings the patient. When a patient is coming with certain symptoms, you look for a sign, and these signs are hypotension, means systolic blood pressure less than 90 millimeter of mercury. You find that there is a signs of shock. Signs of shock means capillary filling time is more than 2 seconds. Peripheries are cold, clammy, dusky colors of the periphery. Patient is having the cold sweats. All these are signs. Signs of acute heart failure means if you auscultate, they have the bilateral basal crepitation in cases of left heart failure. Or when you look at the JVP, there is a raised JVP and patient is success. And patient may have the initial phases of hypoperfusion. Patient may have the irritability, but in the late phases, these patients may become unresponsive or may respond very poor. So a patient, if we take the history, the patient's relative can give a very clear history that he was talking just 5 minutes back, but for last 5 minutes, he was very irritable during that time, but now for last 5 minutes, he is a bit drowsy, and when we talk, he just responds and then he just sleeps. So this is very, very important. Whether it's a bradyarrhythmia or it's a tachyarrhythmia, at this point of time, we need to understand if the patient has come with a symptom, and if any of these signs are present, that gives us a clue that this patient is unstable. And if not treated aggressively, this patient may degenerate or may develop a cardiac. But if the patient is having only symptoms and there is no signs of hypotension, hypoperfusion, acute heart failure, or altered mental status, it means the patient is having symptoms, but patient is stable. And we have a time to think what type of arrhythmias are it, what kind of a tachyarrhythmia, what kind of bradyarrhythmia. We have a time to make the diagnosis. So we have a time to do an ECG. We have to do a time to keep monitoring these patients and wait for an expert opinion to treat this. But if the signs are present, you don't have a time and you need to treat this patient immediately and aggressively, irrespective whether it's a tachyarrhythmia or it's a bradyarrhythmia. So let's talk about the tachyarrhythmia. Tachyarrhythmia means when the heart rate is more than 50, and we understand that it can be a wide complex tachycardia or narrow complex. When we talk about narrow complex tachycardia, it can be any tachycardia like a sinus tachycardia, patient is having atrial fibrillation, atrial flutter, supraventricular tachycardia, or any junctional tachycardia. White complex tachycardia means it's originating from ventricle and it can be a ventricular tachycardia. So, what should be our approach when we come across with any kind of a tachycardia? So, the first thing we should remember airway, breathing, and circulation. So, if the patient is talking, it means his airway is big. Breathing, we have to look for a breathing, and if the breathing is not appropriate, support this patient with oxygen. If maybe patient may require non-invasive ventilation, if he is not breathing well, may require intubation. So all depends on the patient condition and what clinical condition patient has presented to you. So give oxygen to this patient. Secure an IV line if already patient is not having an IV line. Attach the monitor quickly so that you identify the arrhythmia. Look for the blood pressure, respiratory rate, oxygen saturation, and analyze the rhythm. If time permits, if this patient is having only symptoms, there is no sign. It means the patient is stable and you have a time to analyze the rhythm. But suppose if the patient is having a blood pressure less than 90, he's having a shortness of breath, bilateral crepitations are there, and oxygen saturation is just 80. So probably this is the time when you should act quickly without waiting even for an ECG report. So quick rhythm analysis even on the monitor will be sufficient at this. But if the patient is stable, yes, you can do a early ECG, you can do the lab test, you start thinking about the causes, and you wait for an expert, or you can treat if it's a treatable cause as per the hit the target. So if the patient is stable, you have a time to think, get an early ECG, check for the rhythm, whether it's a regular or irregular, and look at the QRS form. This will give you a very good guide that whether it's the wide QRS complex means the ventricular arrhythmia or narrow QRS complex means it is any kinds of a supraventricular, means above ventricle. It can be sinus tachycardia, it can be atrial fibrillation, it can be atrial flutter, it can be supraventricular tachycardia, junction. I'm sure yesterday we had discussed about how to differentiate these different kind of these narrow complex, regular and irregular tachycardia. So if the QRS duration is less than 0.12 seconds, means less than 3 small square in the ECG, it is the narrow complex. You can see this, the second one and third one, both are narrow complex and normal duration is around less than 0.12. So in this situation, you have a time, you can do a medical analysis. You don't require electrical therapy because your patient is stable. So you can do a vagal stimulation, vagal management. But important point here to remember, this should be done under monitoring. So whenever you are doing a vagal stimulation, first, you should be very clear that you are not breaking any clot while doing the carotid sinus. Because the most common method of doing a vagal stimulation is the carotid sinus massage. So you're not breaking, it can lead to a stroke if there is a break of any thrombus and there is embolization. Second, whenever you do a vagal the maneuvers by doing the carotid sinus massage, few things you should remember. The first, you should have a well-working monitor which is giving a continuous increase. Because whenever you are doing a carotid sinus massage, your eyes should be continuously on the monitor, because while doing it, there can be sinus bradycardia, or even sometimes there can be sinus arrest. So you should have several drugs readily available in hand, including adrenaline, atropine, and xylone. If possible, transcutaneous spacer may be kept if possible. And whenever you are doing, you should do on either side. You can do on the right side, massage for 5 to 10 seconds up and down on the carotid sinus, which is situated just lateral to your thyroid cartilage, precoid cartilage, and you feel the carotid pulse and you move up and down for 5 to 10 seconds. And while doing it, keep your eyes continuously on the monitor. If after 2-3 attempts it is not reverting, you can try on the left side, but never attempt on the both sides, because you will press, the carotid flow will go down, and there will be hypoperfusion and patient being unconscious. So these are the things whenever you are doing a vagal maneuver in the form of carotid sinus massage, you should keep in mind. You can use adenosine. Already has been discussed that adenosine is a drug which should be given very quickly, very rapidly, And this is the only drug which requires a flush with a 20 cc of saline, even in a patient who is having a normal circulation. Otherwise, we do a flush with only during the cardiac arrest situation. But because adenosine, as soon as it comes in the contact of the blood, it metabolizes very quickly. So it has to reach to the heart for its action. So what we do, we connect with a three-way or bivalve. We connect one adenosine 6 milligram on one end, and on the other end, we connect a 20 cc of saline. We push adenosine and flush with 20 cc of saline so that it quickly reaches to the heart before it gets metabolized. So adenosine, you can repeat a dose higher. You can use the dose 12 milligram as a second dose. First dose should be 6 milligram and next should be 12 milligram. Again, with adenosine, you should be careful because it's a short-acting drug, so there can be sinus pause, but it recovers very quickly. Do a 12 ECG and get expert consultation because your patient is stable. But keep monitoring this patient. This is very important because at any point of time, if this patient gets unstable, you need to act very quickly. And we remember that the signs of instability is hypotension, signs of poor perfusion, acute heart failure, or altered mental state. So, for a stable patient, we can use, if the patient is stable, we have a time to think regular, irregular, whether it's a white complex. So if it is a white complex tachycardia, if it is a white complex tachycardia, means QRS duration is more than 12 milliseconds. It means more than 3 small square on ECG. So it is the time to use antiarrhythmic drugs. Antiarrhythmic drugs, the first line drug which is available in India, which we most commonly use is the amiodarone. The dose here is 150 milligram should be given over a period of 10 minutes. In cardiac arrest, we used to give 300 milligram as a bolus push followed by 20 cc of saline flush. But here we give 150 milligram amiodarone over a period of 10 minutes with a continuous monitoring because it's a myocardial depressant drug and may lead to a hypotension. The other drug for the white complex tachycardia we can use diclofenac and magnesium sulfate, especially if there is a dorsal bronchitis, which is the drug of choice, is the magnesium sulfate. So for monomorphic ventricular tachycardia, probably drug induced, but drug we can use. But if there is a polymorphic ventricular tachycardia, it should be treated as ventricular fibrillation, cardiac arrest, because there is no perfusion during the polymorphic ventricular tachycardia. And if the patient is unstable, then whether it's a regular, irregular, whether it's the narrow complex or wide complex, immediate cardioversion is indicated. Cardioversion means using a synchronized shock, controlled shock with the use of defibrillation. We take consent if condition permits. If the patient is very unstable and you are not sure about the airway management, then possibly sedation should be avoided. And if time permits, you can take expert opinion. But if the patient is unstable, don't wait for expert opinion. You have to do immediate cardioversion. So cardioversion, if possible, take the consent. If you are capable of managing airway and you are careful about the hemodynamics, then you may give sedation. Otherwise, do not give sedation. Just do cardioversion immediately. So there are steps of doing that. As we remember, as we discussed the defibrillatory steps, here you have to press sync button on defibrillator so that the rhythm is synchronized. The top of our wave, the moment you press the sync button, you will see a star or arrow or pointer at the top of our wave. And every time when you are doing a synchronized cardioversion, you should always press the sync button. That there is different energy when we do for a different types of arrhythmia for synchronized cardioversion. For the paroxysmal supraventricular tachycardia, we start with a 50 joule. We escalate if it is not responding to 100 joule, 200 joule. For a monomorphic ventricular tachycardia, we start with a 100 joule and we can escalate to 200 joule. For the biphase, if it's a monophasic one, then definitely we can go up to 360 joule. Polymorphic ventricular tachycardia should be treated as a ventricular fibrillation. So here you are not going to give synchronized shock because there is no R wave in this. So you just treat it like a VF. You do a defibrillation starting 120, 200, and if it's a monophasic defibrillator, you go up to 360. Atrial fibrillation, it's the notorious kind of narrow complex tachycardia. So you start with the 100 joule and you give 200 joule if it is not responding to the first shock. Atrial flutter usually starts with the 50 joule. You can increase to the 100 joule, or if it's not responding, you can use the higher shock. But remember here, whenever we are doing a cardioversion, after every cardioversion, check the pulse, blood pressure, and look at the patient for breathing and oxygen saturation. This is very, very important because after cardioversion, there can be hemodynamic changes, and that we need to monitor. So key features, what we should remember when we are talking about the tachyarrhythmia management, if there is no pulse, follow the cardiac arrest. If the pulse is present, so look for whether it's a stable or it is unstable. If it is the stable, then you can use the medical management in the form of, if it is a narrow complex tachycardia, you can use vagal manuals, you can use the adenosine. If it's the wide complex tachycardia, you can use amiodarone or you can use xylocar. But if the patient is unstable, immediate cardioversion is indicated without any delay. The second thing, what I want to emphasize here, look for a cause. Treat the cause is always a priority because it is possible a patient is having a heart rate of 160 and he's running a fever of 106 degree Fahrenheit. Then it means treating the underlying cause, treating the fever is a priority, not the tachycardia. If you try to treat this tachycardia, probably your patient can collapse, which is very common in ICUs. A patient of septic shock having a compensatory tachycardia of 160, and we try to reduce the heart rate and patient collapse. So, two things we should remember, whether it's a tachyarrhythmia or bradyarrhythmia. First, look whether the patient is stable or unstable. And second, what is the underlying cause? And treating underlying cause is always a priority. Now coming on the bradyarrhythmia. So if we classify the bradyarrhythmia, by definition, we know that when the heart rate is below 60, it's called as bradycardia. And if it goes below 50 and the patient is symptomatic, it's a bradyarrhythmia. Usually symptom appears when the heart rate goes below 50. So if we classify it can be classified as sinus bradycardia, sinus node dysfunction, and different degree of AV block. Sinus bradycardia, we know the sinus bradycardia when the heart rate is less than 60, T wave is followed by QRS complex. There is a 1:1 ratio. Only thing, the rate is less than 60. Sinus node dysfunction, which was previously called as when there is a conduction abnormality through the SA node. So previously what we call it as sixth sinus syndrome. Now it is classified as a sinus node dysfunction. So you may get P wave, you may not get a P wave. There can be long pauses. There is several reasons for developing a sinus node dysfunction. It can be old age. It can be some kind of degenerative changes in the conduction fibers. But what is important again here, where it is symptomatic and it is leading to hypotension. When there is a hypotension, then it needs immediate. Otherwise, probably it can be, if the patient is stable, he can be a candidate for permanent pacemaker, but doesn't require any treatment if the patient is. The third very important and most important thing for us as a CCLS provider is the AV block. AV block, it can be incomplete or complete. Incomplete again divides into two, first degree AV block and second degree AV block, and complete, what we call it as complete heart block or third degree. The second degree is further divided into Mobitz type 1 and Mobitz type 2 block. Mobitz type 1 is commonly called as Wenke-Bach's phenomenon. So in next slide, I'll be just quickly going through how we diagnose easily these first, second degree and complete. It is not difficult to identify the first degree AV block because here, where now I'll just ask everyone to recall the ECG, where P wave, one P wave followed by one QRS complex. So the relation of PQRS is 1:1. Only abnormality in the ECG is prolongation of the PR interval. The normal PR interval is 0.1 to 2.2 seconds, means 3 to 5 small square on ECG strip. But if it goes beyond 5 small square or 0.2 seconds, it means the PR interval is prolonged. And that is what we label it as first degree AV block. You can see on this ECG as well, there is a increased PR interval. Now, the question, the difficulty comes to differentiate between second degree type 1, second degree type 2, and complete heart block. Why really we need to differentiate? Because second degree type 1 is a relatively safer block where you do not expect much hemodynamic instability. But second degree type 2 and the complete heart block are a dangerous block. These blocks can quickly lead to hemodynamic instability and they can collapse the patient. So we should know how to differentiate. The best way of differentiating these three blocks, remember three things. One, what is the RR interval? Whether RR interval is regular or irregular. Then, what is the PP interval? Whether it's a regular or irregular. So, if the RR interval regular and PP interval is regular, and P waves are more than QRS complex, which is the pathognomic for any kind of a block of second degree type 1, type 2, or complete heart block, it means there is a block. Because when we call it as a block, when there is no conduction is happening from AV node. It is generating from SA node, but it is not passing through the AV. So P waves will be more than QRS complex. That means the block. So when you look at the regularity of the rhythm, if the PP interval and RR interval are regular, it means, and P waves are more than QRS complex, it means it is a complete heart block. You can confidently diagnose it as a complete heart. So now the difference comes, we have to differentiate between two second degree type 2, second degree type 1, and second degree type 2. To differentiate these two, we look at PR interval. If the PR interval, you can see here in this, if the PR interval is fixed, you can see here, if the PR interval is fixed, that means it's a second degree type 2 block. And if the PR interval is variable, and the variability is, you can see here, there is a prolongation of PR interval followed by a drop beat. You can see here, this P wave is followed by QRS complex. There is a bit prolongation, but still QRS complex is there. There is a further prolongation, and still there is a QRS complex. But after this P wave, you can't see any QRS. So this is what we call it as Wenckebach's phenomenon. So if there is a prolongation followed by a drop beat, we call it as second degree type 1. So this is how easily we can differentiate between second degree type 1, second degree type 2, and complete heart block. Because first degree AV block is easy to identify that there is only prolongation of PR. So the same approach will be here. Two questions you have to answer. One, is the patient stable or unstable? And second, what is the possible underlying cause? And again, treating underlying cause will always be a priority. So same management, if the patient is conscious, patient is, it means airway is protected, you assess for the breathing, support the breathing with the oxygen, NIV intubation, depending upon the patient condition. Not every patient will be a fan. Secure an IV line if already not having the IV line. Attach the monitor, look for the heart rate, try to identify the rhythm, check the blood pressure, and that will guide you that the patient is stable or unstable. Look for the temperature because hypothermia is another important cause for the bradyarrhythmia. And remember, bradyarrhythmia is hypoxemia is the most common cause of bradyarrhythmia in the pediatric population. Then you analyze the rhythm. If you establish that the patient is unstable, that means patient needs to be treated immediately. And if the patient is stable, get a 12-lead ECG done. Send the lab test depending upon what you are suspecting, and think about the underlying causes. If the patient is stable, you have a time, check rhythm, analyze the rhythm, and look for what is the rate of intrinsic cardiac pacemaker. Because we know that the primary pacemaker, it's a sinus node, rate is 60 to 100. If it is less than 60, it means probably AV node is working, and if it's less than 40, it's a ventricular rhythm. But remember, ventricular rhythm is usually, if it is the idioventricular less than 40, it is a non-perfusive rhythm. So that we should always remember. Usually, if it is the AV nodal junctional rhythm, there will not be any P wave, QRS complex may be narrow, and patient may have a blood pressure, but it may be hypotensive. So, how do we evaluate the bradycardia or bradyarrhythmias? Heart rate less than 60, we have to look for whether it's a physiological or it's a pathological. Physiological, when we sleep, our heart rate goes down. Athletes, if they have even heart rate of less than 40 and they are comfortable with that, or any vasovagal attack, syncopal attack, there the heart rate may go down, or somebody has a high resting vagal tone, or during cough also we have bradycardia. Pathological condition, when there is a inferior wall MI, sixth sinus syndrome, any kind of IV block, our patient is having a myocarditis, our patient is on any beta blockers or antiarrhythmic drugs, or because of any traumatic brain injury, patient is having a intracranial tension, pressure is increased, which leads to bradycardia. Patients, hypothyroid patients, or any severe metabolic acidosis, hypothermia, hypoxia, or insufficiency can lead to bradycardia. Or even hypokalemia or hyperkalemia may lead to bradycardia. So we have to treat the correctable causes as well. So any slowing of heart rate, even in the physiological condition also, if the patient is having a symptom and there are signs of hypoperfusion, we must treat it. So if the patient is stable, you have a time, keep monitoring this patient, do a early ECG, ask for an expert opinion, and treat the underlying cause. It is most common cause in adult patients is acute coronary syndrome, mostly inferior small MI or right ventricular MI. So in those, we have to aggressively address the acute coronary event along with the treating the radial. If the patient is unstable, the first immediately administer atropine. The dose can be repeated after every 3 to 5 minutes with a maximum dose of 3 milligrams. Usually, for the higher kind of block, means second degree type 2 or complete heart block, atropine will not be effective. Always look for a transcutaneous spacing, and till the time you are getting or preparing for the transcutaneous spacing, we can start adrenaline infusion or we can start the dopamine infusion. Adrenaline infusion should be started at a rate of 2 to 20 micrograms per minute. And the dose of dopamine should be 2 micrograms per kg per minute, and you can increase the dose depending upon the response of the patient. There are certain situations they really need a special attention where even the patient is stable, you really need to keep the standby pacing for these patients because they usually do not respond to the atropine. If the patient is having a recent history of ACC, or there is a second degree type 2 block, complete heart block, or alternating bundle branch block. Because these three, second degree type 2 block, complete heart block, or alternating bundle branch block, are suggestive of acute coronary event. Suppose you did an ECG, you saw that there is a right bundle branch block. After half an hour, you repeated ECG, there is a development of left ventricular block. So all these kinds of alternating bundle branch block are suggestive of acute coronary event. And here we should always have a standby pacing, even the patient looks stable. So the key feature for bradyarrhythmia management, atropine, first line drug, but again I'll emphasize, read the underlying cause. If the patient is hypothermic, correct hypothermia. If the patient is having a hypoxia, correct hypoxia. If the patient is having a acute coronary event, that has to be addressed along with the treating the bradyarrhythmia. So atropine is the first line, but it may not be effective in second degree type 2 or complete heart block. These patients will require immediate transcutaneous pacing. And pacing, always remember that there should be adequate capture, mechanical capture due with the pacing. That should be ensured by a good amount of pulse improving perfusion while using a transcutaneous pacing. You should always call an expert because transcutaneous pacing is painful. You can't continue it for a long time because there can be inconsistent capture and it is uncomfortable for the patient. So immediate transvenous pacing should be arranged and that should be put by the expert. By that time, you can always start with the dopamine or epinephrine infusion. Dopamine starting with the 2 micrograms per minute and epinephrine 2 to 20 micrograms per minute. This difference we should always remember may help us to improve the eye. Thank you very much. I'll be happy to if there is any question or any query.
Vivek, very nicely you described the this management of radiant academia's modalities. We will have discussion on this at the end of the other two lectures. Where first of all, we'll have a overview of acute coronary syndrome, and I'll invite Dr. Ravi Teja. Are you ready with your presentation?
Yes, sir.
Meanwhile, people can write questions, and I also have written one question. You can answer in the chat box. This is very important, which we are going to recollect later on. Today, I don't see anybody writing. Yes. Okay. So, Dr. Vivek, do you agree all the answers have come? Chest pain, altered sensorium, and what else? Hypotension, signs of shock, somebody has written. Acute heart failure. Dr. Vivek? Dr. Vivek, are you reading the chat box? I think that's enough. I think most of the things have come, so I'm glad that you are listening the lecture very carefully.
Sir, I have just I have written that I have only written these things, altered sensorium and these. There are four things important. One, hypotension, blood pressure less than 90 millimeter of mercury systolic, not the diastolic. Second, if the patient is complaining of chest pain. Third, he has a recent altered sensorium. In the beginning of hypoperfusion, he will always be irritable, but in the late phases, he becomes drowsier. And when we auscultate these patients, if he's having acute left heart failure, he will have a bilateral basal crepitations at the bases. And if there is a right heart failure, there will be raised JVP.
Right. Perfect.
We should remember one way that every organ perfusion is compromised, the organ will not work. Starting from brain, patient becomes drowsier or irritable. If the chest hypoperfusion, the chest pain will be there. If there is and the fluid accumulation with the lungs, so we'll get a crepitation. Urine output will be a late feature for it because it takes few hours to drop in the urine output. I think I have cleared the question.
Perfect. Perfect. Thank you. So, Dr. Ravi, we can go ahead.
I'm audible, sir. It's clear. My screen is sharing.
Yes, everything is perfect.
Good evening, everyone. Good evening, the dignitaries, for giving me the beautiful opportunity of presenting this topic. Good evening, all of the students who have taken the interest to learn something to save a patient in your future. These are your future patients. So all this we are discussing in a broad spectrum under the umbrella of CCLS workshop. In CCLS workshop, as you already know that we are not worried about the diagnosis of the patient's age, sex, and area, anything. So, but we have to have only two of the diagnoses to be learned little bit deeper. Those two diagnoses are acute coronary syndrome and stroke. Why we are only interested about this acute coronary syndrome and stroke because these are, if the changes are reversible in any other system, we can easily correct it. But the changes in this myocardium and neural cells, those will become irreversible after a certain amount of period. So in this short amount of window period only, we have to act for a better outcome. Anyway, our final goal is to have a sound patient, not only getting the ROSC back. We have to do it at a right time to have a sound patient so he can depend on his own, not on anyone else. Coming to the acute coronary syndrome. I'm working in the emergency department of RIMS Srikakulam. So I'm presenting you this. So introduction. This is a condition associated with the sudden reduced blood flow to the heart. Basically, it's a imbalance between the demand and supply. When there is decreased supply than demand, then the patient will have the symptoms. Main symptoms are severe chest pain or discomfort. It's a medical emergency and we need immediate care. Our final goal is to improve the blood flow and treat the complications. Even though we are improving the blood flow, after a certain period of time, we can't reverse some of the complications. So we have to act fast and we have to improve blood flow to the distal part of the infarction. In this ACS spectrum, we are going to talk about the three types of ACS. One is STEMI, ST elevation MI, NST and non-ST elevation MI, and unstable angina. So how are we going to differentiate, first of all, by this clinical signs and symptoms, and how are we going to diagnose it? First, we are going to the cognitive part, knowledge-based. Pathophysiology. Main culprit is atherosclerosis. This can happen to not only coronary arteries, but can any arteries in the body. It can be happen to brain, limbs, or even cardiac arteries. Atherosclerosis is a multifactorial cause. Due to the atherosclerosis, there will be a formation of plaque. Plaque is nothing but fat deposits of muscle cells inside the endothelium. So when we are looking the arteries as a tube, we are having a radius, diameter, flow, multiple factors will be happening in that. So here, due to formation of the plaque, we are having the decrease of radius. According to Pausely's equation, when there is decrease of radius by one part, there will be decrease of flow by 4 times. So even though there is a less decrease in radius, it will greatly affect the resistance and also the flow. Coming to the coronary arteries, in the first picture, we can see a normal artery. There is normal blood flow without any plaques. Even there will be some plaques in many elderly people, which doesn't cause any of the major symptoms. But if the plaques are more, like if you are seeing in the second picture, it can cause unstable angina or NSTEMI. So here in the second picture, the blood flow is greatly reduced. There is more resistance and there is more turbulence. Turbulence also will cause the damage to the endothelium, which will trigger a platelet aggregation and also a thrombus. In the third picture, you have seen that the plaque has been ruptured. There is a damage to endothelium. And whenever there is a damage to endothelium, the blood will think it is as a foreign body and will try to clot itself, starting with the platelets. Platelets then trigger the thrombus formation. You can see the cross section of all the elements in here. In the stable angina, there will be a plaque, but it is not that much obstructing the lumen. When the patient of stable angina is taking rest, the pain will come down. Coming to the ACS spectrum, in unstable angina, the plaque is unstable. In stable angina, the plaque is stable. There is a patent endothelium membrane which is not disrupted. In unstable angina, remember, like unstable plaque, there is small disruption and there is starting of platelet aggregation, but there is no formation of thrombus. In the next step, non-ST elevation MI, there is formation of thrombus, but there is some lumen is there. Blood is still flowing, but at a greater resistance and a greater turbulence. Coming to the next last step, stemming, there is complete blockage of the artery by thrombus. So no blood is going distal to this cross-section area. So we have to intervene very immediately. As we discussed, this is a multifactorial cause. There are some modifiable and unmodifiable. Modifiable are smoking, obesity, diet, lack of exercise, hypercholesteremia, uncontrolled hypertension, and sugars. And unmodifiable, increase of age. Due to increase of age, there will be decrease in vascularity and there will be more damage to the arteries. Male gender is unmodifiable and ethnicity, family history also is a culprit. If the previous genes and ethnicity are having high risk, those people can have easy MI. Signs and symptoms. When the patient is presenting to the ER, patient might be having chest pain, shortness of breath, sweating, dizziness, syncope, nausea, and vomiting. You have to remember all these symptoms because these are the red flag signs. Even though patient currently is not having any chest pain or any of these symptoms, patient is telling the history of 1 hour back at the home. Patient had a episode of dizziness and syncope. You have to intervene immediately by some interventions in the ER. Signs you can watch are for pallor, tachycardia, pulmonary crepitations. Pulmonary crepitations are the initial stage of pulmonary edema, raised JVP. Due to raised JVP, you can tell that the patient's right heart is failing enough. Murmurs. There can be a formation of new murmurs because this infarcted material is affecting the papillary muscle. Papillary muscle is what controls the valves. So the valve is not functioning properly and we are able to hear the murmurs. Coming to the diagnosis, management. This management is combined by the three main parts: history, examination, and investigations. We had the history and the clinical examination and how to diagnose. 12-lead ECG. When the patient is arriving, whatever might be the diagnosis, if the patient is having these all symptoms or signs, we have to take a 12-lead ECG within 10 minutes time frame. Whatever might be the condition, patient had an OP, you are done writing the history, you are taking other things, ECG can be taken parallelly within 10 minutes because it's crucial to jump into the next steps. As we have learned in the ECG yesterday, how to determine the ECG, abnormal, normal, how to interpret an ECG. If there is ST elevation, it is diagnosed as STEMI. For diagnosing STEMI, only one investigation ECG is enough. No need to go to higher like biomarkers or an angiogram. To diagnose a non-ST elevation MI, the ECG can be a normal, completely normal, or there can be some ST depressions. Then to prove it, we have to go for a troponin test. Within the troponin test, if it is raised, there is an ST elevation MI. Troponin is raised when there is a thrombus in arteries. In NSTEMI, there is already a thrombus. So NSTEMI will be diagnosed. The troponin T is not raised, but the patient is having classical history of MI. It is unstable angina. The patient had some pain at home. After reaching to hospital, the pain has completely come down. The ECG is normal. Troponins are not raised. It can be a stable angina. We have to observe the patient for further changes in ECG. Coming to the ECG and biomarkers, as we can see, the first picture depicts the normal ECG. The second picture, we can see the segment ST elevation over the isoelectric line. Isoelectric line means it's a segment of T and P. It's not PR segment, it's TP segment. Over this TP segment, if you see any elevation of ST, it is STEMI. And this STEMI also, it will be different according to the leads. If in the limb leads, like 1, 2, 3, AVL, AVR, AVF, you need to have at least one small box elevation of this ST segment of any two adjacent leads. Coming to the chest leads from V1 to V6, adjacent leads, you need to have at least two small boxes. If there are two small boxes elevation in the adjacent leads, then you can tell it as a MI, STEMI. In NSTEMI, there will be a depression of this ST segment below the isoelectric TP line. And sometimes NSTEMI also can come with T wave inversion. This is in the starting stages. But if the STEMI is continuously progressing and the affected area is completely damaged, it went into the irreversible damage, then we can see a long Q wave. It is like we have crossed the time. It is not the time for thrombolysis. The myocardium has already damaged in that specific area. This the lead is representing. You can also see after how much time the biomarkers are elevating. Regularly, we will be checking troponins now because rest of the things are obsolete in the current generation. Until now, we have done with the cognitive part, knowledge part. From now, what we can do in a patient of suspected ACS. Pre-hospital care starts from the home. In the home, we can, some people with the knowledge of ACS and all these things can diagnose, can suspect this can be a heart attack in a general terminology. From the home into the ambulance and during the transfer to the hospital. Anyway, we have to follow the CCLS protocol and we have to prefer for CPR and defibrillation. In the CCLS ambulances, we will be provided with the 12 lead ECG, defibrillation and all the equipment which we are needed to revive the patient. We have to always assess the ABCs continuously. And we have to take a 12 lead ECG in the ambulance. If the doctor is going, it's fine, they can diagnose. If a technician is going in the ambulance, they can take a 12 lead ECG in the ambulance and can share via WhatsApp or monitoring system the hospital is having. Then we can prepare the ER and the cath lab for the upcoming patient. Oxygen is only needed when the patient is having increased respiratory rate or decreased saturation or increased work of breathing. Without that, we should not give oxygen. Might be learned regarding MONA. What is MONA? Morphine, oxygen, nitrates, and aspirin. Aspirin we can give even though it's a case of STEMI, NSTEMI, or some other diagnosis. It can be a bad pain due to acute gastritis. Giving one shot of aspirin doesn't change anything if you are not having any ECG evidence or not. So you can give aspirin, but in the case of gastric ulcers, it might lead to more ulcer perforation and all. So morphine we can give, but better drugs are came into the ER and in the ambulances, that is fentanyl. Fentanyl we can give to relieve the pain, excruciating pain, and oxygen only if it is needed. If we are giving oxygen in every suspected ACS case, oxygen will cause vasoconstriction. There is already less supply and there is already platelet formation and thrombus in the artery. By giving more oxygen, which the patient is not needing at the time, you are causing harm to the patient. So oxygen should be given only when needed. Decrease saturation, increase respiratory rate, pulmonary crepitations. And nitroglycerin, we should not give nitroglycerin if the patient is having signs of shock or shock. If the patient is having cold, clammy extremities, sweating, patient is having less BP, less than 100 or 90, we should not give because it will lead to cardiogenic shock. We have to alert the receiving hospital with the cath lab. When the patient is arrived into the emergency department, we have to triage the patient into the red zone. We have to continue the CCLS protocol always. When you are in a doubt or the patient is deteriorating in front of you, do not panic. Every time start from the airway breathing circulation. You will get a clue. Even though irrespective of the diagnosis, if you found any problem in the airway breathing and circulation, you can revive the patient instantly. And you will take a 12 lead ECG in the department again because you need to know the progression of ST elevation is increasing or decreasing or any arrhythmias like bradyarrhythmia and tachyarrhythmia. If you see for the inferior wall MI, bradyarrhythmias are more common. So we have to treat brady and tachyarrhythmias also as required. You'll have to give oxygen as per requirement. You have to take the physical examination and history again. Lab tests are only needed when you are sending a patient to cath lab for coagulation profile and viral markers. Or if it is not STEMI, to diagnose NSTEMI or unstable angina, we have to send the lab test. We have to get a portable chest X-ray. Never send a suspected ACS case to the radiology department, which is far away, because we cannot monitor the patient. Never take that risk. Do a portable X-ray here only. If it is a STEMI, we have to alert the cath lab, and if we are having a risk factors, check for the thrombolysis. There is a pre-checklist for the thrombolysis which you have to analyze, and the patient is not having any contraindications, we can proceed with thrombolysis. Actually, thrombolysis can be done where in that institution if cath lab is not there. The patient is coming, if we are having a timer, patient entering into the ER is, the timer will start. Within 30 minutes, we have to thrombolyze. 0 to 10 minutes is the time for the ECG. We have diagnosed STEMI at 10 minutes, and within another 20 minutes, we have to start thrombolysis. It is called door to needle time. Needle is a thrombolysis needle. And if we are having a cath lab and a cardiologist in our institution, we have to shift the patient within 90 minutes to the cath lab. So people might ask what to do if there is no PCA. We will come to know there. So it's a STEMI. The patient is having a onset of symptoms of more than 12 hours. There is ongoing ischemia. We can send the patient to primary PCA. Primary PCA is a terminology where we use only during STEMI. There can be many PCAs, but primary PCA should be used only during STEMI treatment. That is a terminology. If the primary PCA is not available, we can fibrinolysis. Fibrinolysis we can do with many drugs. There is classic drug called as streptokinase. Now, many institutions are having RTPA, recombinant tissue plasminogen activators like retiplase, tenetiplase, and altiplase. These are better, easily administrable, and have less complications. So many prefer the RTPA drugs in the corporates. So, but if the symptoms are less than 12 hours, we can directly send to PCA if it is a capable hospital. If your hospital is not having a PCA, what to do? If it is a short distance transfer, we have to transfer the patient to primary PCA. You should not waste the time to have thrombolysis. As your hospital is having thrombolysis and you know how to thrombolyze, you should not waste thrombolysis, because thrombolysis is never a specific therapy. It is only a bridge to PCA. So anyway, the patient will be needing PCA. So better to transfer to a nearby facility. So how to know which is shorter distance and which is longer distance? A place where we can reach within 120 minutes. Within 2 hours, if there is a cath lab, you can ship the patient immediately. Within 2 hours, if there is no cath lab, better thrombolyze the patient, stabilize the patient, and then you can shift to the PCA center. Coming to NSTEMI. NSTEMI is primarily of medical management, will give dual antiplatelet therapy and anticoagulant. Anyway, in STEMI also will give dual antiplatelet therapy and anticoagulant before we are introducing thrombolysis or PCA. And even NSTEMI is no exception for PCA. We have to give antiplatelets, anticoagulants, but we can treat the patient into a elective PCA. See here, PCA is labeled only PCA, not the primary, because it is elective. And if we are aiming of doing one stenting for 1 artery or 2 artery, PCA is enough. If there is a problem in greater than 2 arteries, we have to do a coronary artery bypass graft. So vein from the lower limbs will be taken and they'll be attached from the proximal segment to the distal segment, bypassing the infarct site. So what is your role in the stabilizing the patient? So we have to continuously have to see the airway breathing circulation. When you know so much knowledge about the drugs, doses, and what they will do in the cath lab, everything, and you are not able to manage ABC, patient will die, because we are, irrespective of the diagnosis, we have to treat ABC. When the patient airway is not patent, we have to, if you know how to intubate, we have to intubate, we have to support the airway. Or if you don't know, you have to call for a help. for an emergency physician or anesthetist who are available nearby, you have to secure airway, manage the breathing, and hemodynamically we have to stabilize the patient. And you have to know how to take an ECG and quick investigations. In some emergency departments, there will be bedside testing of troponin, which we can do within 5 minutes of time. And we have to understand the disease and time management. Within 10 minutes ECG, within 30 minutes thrombolysis, or if you are having cath lab, within 90 minutes you have to shift the patient. Recent guidelines are telling that if your ambulance is completely equipped, you can bypass ER also, directly shifting the patient to the cath lab. You have to counsel the patient attenders for a primary reperfusion therapy. Reperfusion can be anything. It can be thrombolysis or PCI, but we have to take the blood to the distal segment, however it might be. And finally, referring to the cardiology unit in the time. Thank you. If any doubts, we will be happy to answer.
Dr. Ravi, excellent.
Thank you, sir.
I thought I also got cleared my doubts about a few things about the time management. You see, I was telling before your lecture that anywhere where there's a pathology is vascular or blood supply oriented and compromised, there has to be a time frame in the management. And the time frame when we have multiple modalities like PCI is also available, and this is also which should get the priority. If one is like that at a distance, you have to shift, and it is longer than 2 hours. So it was very, very nicely described. Thank you so much, Ravi.
Thank
And
you,
we'll have a lot of discussion. I think let me finish the stroke lecture first. I don't know where my lecture is lost. I kept it on the desktop. Yes, got it. Can you see the screen?
Yes. Yes, sir. We are able
Okay.
to see.
Okay, so this is a similar condition, similar cause, and what Ravi described that which needs the attention in time frame. And there's a reason these two subjects, acute coronary syndrome and stroke, has been included in the course because they are the most common emergencies we get in our emergency department or even within the hospital or outside the hospital. So he has described many things which he described for the management are true and applies for stroke patients also. So it has become very easy for me to cut short my lecture a little bit because some principles are the same. So we'll go with the presentation. Now, as I say, this is tremendous scope of learning the background and the overview of stroke for CCLS provider. because they keep on happening within the hospital or outside the hospital. But most of the time they happen outside the hospital, at home or at anywhere of the workplace also. And when I say out of the hospital and within the hospital, when I say within the hospital, it means a hospital where there is a complete neurological services available. Otherwise, a small nursing homes or a general surgeon's nursing home or an ENT place or radiology suite, which is not a part of the multi-speciality hospital, I consider even if they are hospital for the patient, it is for us, for stroke patient or acute coronary syndrome, they are out of the hospital because they don't have either cath lab or neurological backup. So stroke can happen anytime. Again, as I say, the time frame is important. So you have to immediately recognize, rapidly transport to the place where the neurological backup is available. A quick diagnosis and management is necessary because if you lose time, these are the two areas, as Dr. Ravi Teja said, where there may be a permanent damage than other part or other system of the body. So this is very important. So the objective is to tell you what is stroke, what are the early signs and symptoms on which you pick up that the stroke is developing, and which we may have to counsel or talk on telephone with the family members if they call from the home. What is the pre-hospital assessment and in-hospital assessment and care? This is what in briefly I'll describe. So stroke is acute neurologic impairment which is following the interruption of blood supply to the central nervous system part. Now, commonly there are two types, the ischemic stroke or hemorrhagic stroke. You know what is the most common stroke we get in our clinical practice? Is the ischemic stroke. About 85%, 80% patients are ischemic. Rest 15% patients are with the hemorrhagic stroke. Now, for this, to understand the early signs and symptoms, many times if you are a doctor known to some family members whose family member is getting a stroke, he will call you. And what you observe is sudden weakness or numbness on any side of the body. It could be on the face, it could be arm or leg, one limb, one side, and there's dropping and weakness of the limb. Or sometimes there may be only dizziness. He complains of dizziness, sudden confusion, like you ask something and he's not able to answer, or loss of coordination. When many times it happens, then you are having a cup of tea and you are having a cup in your hand and you try to put it back, you don't put it on the saucer, you put it on the side, or you may drop it from the table. So like that, there's a loss of coordination. Sometimes there is a altered speech or slurred speech or disarticulation, understanding disability, and this speaking inability sometimes represents as the first sign of stroke. And you ask something and they answer differently. Sometimes there is blurring of vision, either one eye or both eyes, and this their patient may complain. Or they complain of severe headache. Anyone who is 70, 75 years of age, never had hypertension, no comorbid conditions, very psychologically stable and happy person, and first time ever gets a severe headache, you have to be suspicious that he's maybe getting stroke. Now, this is true even in the younger generation. Nowadays, we get 30, 35, 40, 45 years of age with aneurysmal rupture or vascular rupture and hemorrhage. They also start with severe headache. However, in that age, there are multiple reasons for the headache, like stress and work environment and overload of the work, and so many financial constraint, family burden, so many things are there to get the headache. But if they get a sudden headache, which they never had for some time or for a long time, you have to be suspicious to get. So when you get such symptoms, you have to suspect the stroke and you have to put them in the battery of investigations, which are absolutely mandatory for quick diagnosis. So when you get such symptoms and you send the ambulance, the outcome is always better if the time interval between onset of symptoms and arrival to the hospital is short. So it is the time frame very important. Now, when I say arrival to the hospital, it's like what in coronary syndrome, Dr. Ravi Teja said, a cath lab place where there's a cath lab and cardiologist backup available. Here, the hospital is the one where there is an imaging facility as well as neurological backup is available. So the action plan is support ABC and oxygenation. Now, you know, when there is a cardiac arrest, the mnemonic is different. It is CAB. The compression is the first priority. Then comes airway and breathing. But when the heart is beating, there is no cardiac arrest. In all the emergencies, it is always ABC. And oxygenation, rapid pre-hospital stroke assessment. Now, you all know Cincinnati pre-hospital stroke scale is very simple and very being practiced by most of the ambulance people abroad. And nowadays, in our trained paramedics, also with some particular hospitals who has a well-developed stroke team and stroke department, where we see the drooping of the face, weakness of the limb, speech alteration, all these are considered and they are noted down. And these are noted down and conveyed to the hospital, receiving hospital. The most important is to establish the time when the patient was normal. So you ask a daughter or son or whosoever was present there, your father or mother got the symptoms like this, right? But when they was absolutely normal, you say, yeah, about 8 o'clock when we were sitting we started having a cup of tea. That time he was absolutely normal. But then suddenly these things started. So you note down the time when the patient was absolutely normal. That time is very important to calculate the next frame of management, time frame of management. Transfer as fast as possible to the hospital where there is a neurological backup and imaging facility is available. Check blood glucose level. In any case of hypoglycemia, it is difficult to diagnose neurological condition. So if you find hypoglycemia, correct it and share the information to the hospital before arrival. And in between, while you are transporting the individual, please do the triage and support of ABC during the transport. So when you reach to the hospital, again, you stabilize, note down vitals, ABC pattern, and give oxygen, IV access, and blood sampling. You send glucose, coagulation profile, CBC, and most important is serum electrolytes. Now, many of the hospitals in emergency department, like they check the troponin T there only, like that, they also check electrolytes and blood gas also at the same place. So it is better to get such investigation done immediately. Do a quick neurological assessment. Cincinnati was already done, but at this stage, you may note down ABPU like alert. Is he alert? Is he responding to verbal stimulus? Is he responding to painful stimulus? Is he not responding like that? Those are noted. And if he is responding, then the neurological weakness on any one side or speech and everything is noted down. And then the patient is sent to the most important investigation is CT scan. So immediately this patient should go after stabilization to CT scan. But if he is unstable, you have to make the patient stable and then send to the CT scanner. Meanwhile, you start taking the history of previous strokes, previous symptoms, any other comorbid conditions like hypertension, diabetes, ischemic heart disease, blocks, pacemakers, so many things. Find out the medications he is regularly taking. Find out the medications he is overdone. Find out the medications he has skipped during a day. And all those things will help us to make the diagnosis. Immediately, when you suspect with the symptomatology and you send to the CT scanner, activate the stroke team. And many hospitals has a separate stroke department now. At least we have in Ahmedabad in a couple of hospitals. And you activate the stroke team so the relevant registrar or the neurologist will come and take over the patient. And meanwhile, get a proper 12-lead ECG also done. Now, CT scan is most important investigation at this stage, where it will differentiate this hemorrhage stroke with the ischemic stroke. So the CT scan, non-contrast CT scan will tell you whether there is a hemorrhage or no hemorrhage. If it is a hemorrhage, it falls in the hemorrhage category, but no hemorrhage with the symptomatic patients or signs are present, it falls in an ischemic stroke category. And you also note down other structural abnormalities like coning or midline shift, particularly when there is an hemorrhage or a rise in intracranial pressure. So that CT scan is very, very important investigation, has to be done as quick as possible, because on the CT scan diagnosis, your next management will depend, because you have to differentiate whether it's a hemorrhagic shock or an ischemic stroke. So next is when you find hemorrhage, which is about in 12 to 15, 16% of the patients, you have to involve a neurologist or a neurosurgeon also, because sometimes there may be a lesion or hemorrhage which requires an immediate surgical intervention and evacuation to reduce the further neurological damage. But if it is non-hemorrhagic, like coronary artery syndrome, we have to consider fibrinolytic therapy with the same principle. And if there is no neurological deficit, if there is a neurological deficit, recommendation is within 3 hours of the symptoms. Now, this 3 hours is the one which is there in the textbook. That's why we have put in the syllabus in our CCLS algorithm. But it is a lot of research going on for the right time for a recommendation for the fibrinolytic therapy, and which could be varying also subsequently. Once it comes in the textbooks and with the evidence base, we'll be able to include them in the syllabus. Now, this is below 18. This is done only for the age group of more than 18 years. Now, the reason why it is not done under 18 years is the ischemic strokes are very, very less common in this young age group. They are mostly above middle-aged to elderly people, and hemorrhagic strokes we get to middle-aged to younger people. So below 18 years of age, aneurysmal rupture and hemorrhagic strokes are noted, but ischemic strokes are not noted. So there is no enough evidence of treating with fibrinolytic therapy in an age group less than 18 years of age, because there are no cases in that sample group or sample size noted with the ischemic strokes. So for fibrinolytic therapy, like in coronary case also, there are contraindications and limitations, like prior stroke, head injury, hypertension, which has to be optimized anyway. You don't aim for 120/80 American standard of blood pressure, but you have to optimize if it is 220, 120, and bring it down to 170, 160 systolic and 80, 90 diastolic pressure. If there is a bleeding diathesis, is a contraindication. Patient with subarachnoid hemorrhage, history of previous intracranial hemorrhage, hypoglycemia, which is relative, where you can always rectify it, correct it, and then you can get it done. Recent MI, recent when the anticoagulants have been used, recent GI bleed, second to third trimester of pregnancy, and major surgery in recent past, like resection of liver or prostate surgeries has been done on a previous day. It will be an havoc situation for the surgeon if it starts bleeding at the surgical site. So these are relative contraindications and limitations. And the reason being, there are, of course, there are complications and side effects, like you all know, intracranial hemorrhage. It can happen with this if it was a simple ischemic case. Other bleeding complications, angioedema and transient hypotension, which may need inotrope support and hemodynamic support for this purpose. Now, as RTPA, Dr. Teja also mentioned, recombinant tissue plasminogen activator therapy is now possible in most of the neuro centers, and probably we have in Ahmedabad, but in Andhra and Visakhapatnam also, there are very good centers where this is possible. And also now we have a neuro cath labs available where we do a lot of endovascular surgeries, stenting, coil insertions for aneurysm ruptures. And this is possible now. So we have a lot of endovascular therapy available in our patients, which has to be done within that time frame, like a time frame we do PCI in coronary insufficiency case. These patients also need a general care, like supportive of oxygen, breathing, ventilation of airway management. They need, if the airway is compromised, we may need a definitive airway. Intravascular volume maintenance is necessary. Control of blood glucose is necessary. Anticonvulsants only when the patient had the seizures, and optimization of blood pressure is monitoring. Blood pressure monitoring is necessary. So this is a general care which is best provided in an coronary in an intensive care unit. Now, there is always a stroke algorithm. Most of the hospitals have their own stroke algorithms, which are almost similar, and you can always get it from your hospital. And many hospitals also have a neuro department, a neurosurgical and neuromedicine, but there is a separate stroke team who look after only the stroke patients. And if it is there, please involve the stroke team and make them take over the patient. And always follow the hospital policy for the stroke. Now, many times, our role as a CCLS provider is, when you find a patient who is symptomatic and has come to your emergency department, you have to suspect stroke, you have to get the right investigation done, and more important is to counsel the family members that maybe they have been stroke. The stroke management, if it is ischemic, has to be done in a very short time frame. So I'm getting a CT scan done, I'm involving the neurophysician, and if it is ischemic, it is just 2 hours, we must get it done within 1 hour for the proper treatment. Or you may have to counsel them to send to the place, which hospital where there is a neurological backup. So this is our role as a CCLS provider, which applies same for the acute coronary syndrome patients also. So if there are any questions, we can address right now. Or thank you so much. This was the last lecture today, and we're going to have a lot of discussion now. Any question on this? We have real experts, emergency medicine people in the group, and Vivek, who can solve our queries if anybody has. Any comments on this? Dr. Ravi, you want to make any comment? Dr. Mahesh Kumar? Dr. Satish?
No, sir, no comments. All good, sir.
Jaya, are you interested to make any comments? Dr. Mohan Maharaj, we have many emergency medicine and critical care people here. Satish Kumar is now OT attire now.
Yes.
How long have you been working? Long hours of working for you.
Nothing like duties and night duty today.
Okay, so now I have left 20 minutes specifically for recapitulating what we learned in these 3 days. Now I am going to, all the delegates, carefully listen every of my sentence now, and I think Vivek also will help me to sort out those certain things. Like suppose you get an emergency call, you are in a code blue team, and you got a call in the ward, or your operation theater patient became serious or something happened, or you've been called to in emergency department, you got a patient who has been wheeled in with some emergency, or it may be in ICU, or it may be in procedure rooms or anywhere. And you are a part of code blue team, and you reach to the victim. What is the first thing you do? Anybody can start writing the answers. I'll wait for 10 seconds to get one answer. Dr. Nodi has written ABC. I think partly I would give you correct. What, when you reach to the individual and you have been called you as a code blue team member, what you are most worried is there is no cardiac arrest. So first thing, it is your own environment, so it is safe. You check for the responsiveness. If it is responsive, you know there is no cardiac arrest. The first thing I will do is check the responsiveness. Correct, Mahesh Kumar, you are right. So first thing I do is the responsive. If the individual is non-responsive, then the responsibility doubles up. Then what do you do next? Is non-responsive. A nurse in the ward has called you in a code blue team, and you are there with your team and crash cart. What is next you do if is non-responsive? What I am going to describe now for 15 minutes is what you are going to do on the skilled sessions on day after tomorrow. If he is not responsive, first thing is to find out is a cardiac arrest or not cardiac arrest. Because if the cardiac arrest is there, you don't have time. Correct. So you check the carotid pulse. When you say pulse, please specify carotid pulse. So I'll check carotid pulse, same protocol, at least 5 seconds, but not more than 10 seconds, along with scanning the abdomen or chest for the breathing. So in that 10 seconds, remember the rule of 10. In 10 seconds, I'll check pulse and breathing. Now say there is no pulse and no breathing, or there is a pulse and no breathing, then you know appropriate management. If both are there, then you start further investigation. You don't give a recovery position, you are in the hospital. If it is outside, you give a recovery position because you are waiting for the help to come. Your whole help is with you only. So you check, you start evaluating further. If respiration is not there, then you give one breath every 5 seconds. You have a bag valve mask with you now. And if both are not there, you start with CPR. Now time comes, you are not only doing BCLS protocol. BCLS is most important, but somebody takes the IV line, somebody connects the bag valve mask with the oxygen, somebody puts the monitor, somebody opens the defibrillator, everything you start doing it and start managing the cardiac arrest situation where you give, when you have a defibrillator, use the defibrillator. If it's a shockable rhythm, give one adrenaline. And how you give the adrenaline? 1 milligram diluted in 10 ml, push the bolus, give 20 ml of saline, follow it with that, and raise the limb to gravitationally help the blood to rush to the heart quickly. So this is the protocol. So that is the cardiac arrest management you start doing. Then 3 to 5 minutes you repeat the adrenaline. If it is a refractory arrhythmia in cardiac arrest, then you think about amiodarone and all. But go back. Your patient was not responsive, but had the pulse and respiration both. Now what? Patient does not have cardiac arrest. Then what will you do? This is how we are going to give you the scenarios on that day, individually. If there is pulse and respiration present and he's not responding, what do you do? Start writing the answer. All PG students should answer, not the professors and faculties. Or PG students are not there. How many people are there? Less number of people are there. Many have left, I think. So please, we don't give recovery position when we are within the hospital. You have to evaluate this individual. Now remember, there is heart beating. So your protocol from CAB changes to ABC. Now ABC comes in the picture. So you give the oxygen with mask, he's breathing. So put the oxygen mask. Then if it is airway management is necessary, you may have to do the airway management. Then comes, you have put the monitors, you have check the vitals, and you make a decision. And he's not responding. So what you do is, normally in this situation, we use OMIV, OMIV, oxygen, monitors, IV line, and vitals. And when you get the vitals, and each team member, if you have one person gives oxygen, other person takes the IV line, third person puts the monitor, collectively within a minute you get the vital data and you decide what are you heading for. He is non-responsive patient, so that means he is unstable. What is his vitals? If his vitals are okay or maybe having 180, 100 blood pressure, you may start thinking about stroke. That way hemodynamically stable patient. So you start thinking about all these things in this patient and check the rhythm, whether it's a bradyarrhythmia, whether it's a sinus rhythm, whether it's a tachyarrhythmia, and your management becomes like that. So when you have a responsive patient, you check, or non-responsive patient, if there is no cardiac arrest, you have to find out the patient is stable or unstable, whether the patient has a tachyarrhythmia or bradyarrhythmia, and your management will change. Suppose you find tachyarrhythmia, there is ventricular tachycardia and blood pressure is 90. So it's a ventricular tachycardia with pulse. He's an unstable patient. He needs what? Look, whenever there's some rhythm disturbance, your aim by seeing the ECG is you try to make the rhythm normal, sinus rhythm. You try to make the rate in a normal range. If it is bradyarrhythmia, your aim is to increase it. If it is tachycardia, then you have to reduce it. So your aim is to stabilize the heart rate. You have to stabilize the rhythm and try to make it sinus rhythm. That is going to help the cardiac output. And your aim ultimately is to increase the cardiac output if the patient is unstable. Am I making it very clear? Now, when you're starting to stabilize this, a team leader starts thinking, very good, Nori has written, Dr. Venugopal Nori has written, start thinking about why this has happened. So you go through the case paper, you go to the old history, you ask about the history, medications, diseases, comorbid conditions, and start coming to the conclusion why he has not got cardiac arrest. He has a heart beating, but he may be in pre-arrest condition. So we have to identify the condition if it may lead to cardiac arrest before it goes into cardiac arrest. So this is how on that day, when you will be on the skill session, you will be evaluating every individual case. And you know, if there is a tachyarrhythmia, if the patient is stable and stable patient, we already described what is unstable patient. If it's a stable patient, we go for the medical management. Like what are the tachyarrhythmias? Can someone write down? Anytime when you see a rhythm, look for rate. Is it tachy or brady? Look for PR interval. Look for QRS complex. And you know, is the P present? No. If there is a SVT, yes. Supraventricular atrial fibrillation, ventricular tachycardia, atrial flutter. Ventricular fibrillation will go in a cardiac arrest situation. So there is no pulse that time. But with pulse ventricular tachycardia is one where patient may be stable or unstable. Am I making it clear? So identify if it is atrial fibrillation is a stable patient, what do you do? If it is an unstable patient, what do you do? You may do cardioversion. So any tachycardia, any tachyarrhythmia with unstable, if you have a cardioversion, use cardioversion and medical management. If it is bradyarrhythmia, blocks and all, then you start thinking about stable patient with medical management, like first degree, second degree, you may use atropine, or sinus bradycardia, who is symptomatic, you may use atropine, or otherwise you may put on epinephrine infusion or dopamine infusion to increase the blood pressure as well as heart rate. And if it is very unstable, the blood pressure has gone to 70, you start thinking about the transcutaneous pacing. Correct. Dr. Nori, you should be in the faculty list. You should be as a faculty now.
Thank
Here,
you.